Okay, sir.
Janki, you only start directly, okay?
Okay, sir.
We are live in 5, 4, 3, 2, 1.
Good evening, everyone. So today we have this is the sixth class of a Pelvic and Acetabular course by John Mukhopadhyay sir and Coxon Khong sir. So today we have a very important topic: two elementary fracture, anterior wall and anterior column, and two associated fracture, anterior wall column with posterior hemitransverse and both column fracture. So first, I'll request Dr. John Mukhopadhyay sir, the chairman of Orthopaedic Research and Education Foundation India, to teach us about the anterior wall column and anterior wall column with posterior hemitransverse fracture. So over to you, sir.
Okay, good evening, everybody. So what I'm going to do is talk about the anterior wall, anterior column, and the anterior column posterior hemitransverse, generally known as ACPHT fractures. And these comprise the anterior group of fractures. Okay, so one needs to recognize these anterior fractures, the group of fractures of the acetabulum. You have to appreciate the fracture geometry, plan your approach and fixation strategy so that you can achieve a staple fixation. Okay, now looking at these three groups of fractures, you can see that they are not the most common fractures of the acetabulum. So definitely the both column, the transverse with posterior wall are far more common. If you look at the anterior column in the various series, it's only about 3 to 4%. The anterior wall is only about 1 to 2%. The anterior column and posterior transverse is somewhere between 4 to 10%. So these are not the most common fractures. I think the anterior column with posterior hemitransverse may often be misdiagnosed for one of the other fractures, and we're going to come to that. So I'm going to talk about these three fractures, but kind of combine the management together. These are basically the anterior wall fractures where the anterior wall is involved. The anterior column fracture extends all the way up the iliac crest and down to the sort of pubic rami. The exit from the ilium could be at various levels. So it could be almost at the level of the top of the acetabulum, higher up, and maybe right up there. So depending on the height, you could, where it exits, you can call them high, low, or anterior column fractures. And then you have the anterior column and posterior hemitransverse, where the fracture line runs kind of vertically in the anterior column, and then there's a transverse fracture line extending into the posterior column. Okay, now this I'm going to concentrate more on the anterior with posterior hemitransverse, because when you manage the anterior column or the wall, which a combination of this is there with the posterior hemitransverse, that will take care of management of the anterior column and anterior wall as well. So most of these anterior column fractures are more common in the elderly, especially in the West. In our own practice, we don't see as many of them in the elderly. We see more in the high energy trauma. And this depends on the position of the limb. So if the limb is externally rotated at the time of impact, then this the head seems to tends to go through the anterior part of the acetabulum rather than the posterior part, where if it is an internal rotation, it would do that. Okay, so you have an anterior wall or column fracture and a transverse fracture of the posterior column. Usually in this, as I mentioned, since the force is directed anteriorly, it's the anterior column which will be more displaced and comminuted, while the posterior one tends to be less displaced and less comminuted as well. Okay, so the anterior fracture is similar to the pure anterior column or wall fracture or the combination. So that's why when we cover this, we'll be covering more or less everything. Okay, you could have an anterior dislocation or subluxation of the femoral head, and you'll see a couple of cases in which you can see that the head has more or less come out anteriorly. a plate of bone may be elevated from the quadrilateral surface. This is also very common, and you may have to deal with that in your reduction and fixation. And because it involves both columns, you will have disruption of both the ilioischial line, as you can see here, and the iliopectineal line, as you can see here. This piece is off from the iliopectineal line. Okay, now if you look at the CT scans towards the dome of the acetabulum, the transverse coronal fracture line would be the fracture line of the column. The vertical fracture line would be the transverse part of the fracture. And if you have an oblique fracture here, it would be the anterior wall fracture. So this is how it shows up on the CT. Obviously, the CT, it depends very much on what level the section is through, and therefore you have to keep that in mind as well. Okay, this shows you this anterior posterior direction of the transverse part of the fracture, which is the posterior. Okay, and the vertical direction of the column fracture. Now, you need to differentiate this from both column fractures. And again, that's why I said there's sometimes confusion about it. And in the both column fracture, it's important to note that this dome part of the acetabulum is completely separated from the axial skeleton. Okay, so you can see this is a separate piece. And it is this intact part of the ilium that gives you the spur sign on the obturator oblique views. Okay, so remember this, for it to be a both column fracture, it doesn't mean that both columns are involved. It means that the dome fragment is separated from the axial skeleton. Now, there can be various patterns, and I'm sure Coxon is going to talk about that later. And the T-shaped fracture is different. That here the T-shape, the fracture line, you have a horizontal fracture line with a vertical stem extending into the obturator foramen, going down to the inferior pubic ramus. Okay, now this is quite different from the line in the anterior column posterior hemitransverse, where you have a vertical line going this way and a transverse line going posteriorly only. So anteriorly, you may have a wall fracture where you'll have a separate wall fragment, but the main anterior column fracture line will be vertical, while the posterior column fracture will be the transverse fracture. For surgery will depend on whether this hip is stable or not, whether the joint is congruent or not. If the weight-bearing area, like you can see here, the weight-bearing area is displaced, or the dome, then there's no doubt that you're going to need to do surgery. Or if there's a significant step or gap of the articular surface. And we've discussed this in the previous lectures. Now, what are the approaches? I think the ilioinguinal approach has for long been the workhorse for these fracture types. Okay, so you can get access to the entire anterior column and a significant part of the posterior column through the true pelvis. You can reduce and fix the posterior column, which is typically transverse in nature. So you can very often get a screw across to the posterior column, and I'll show you an example of that. The only thing is, sorry, Janki, is there a problem?
No, sir.
Okay.
No problem.
Sorry. You can reduce and fix the posterior column. The thing is, you can't see the articular surface through this approach, although you can see part of the dome through some of the fracture lines, which may be useful when you're trying to reduce the impaction. Okay, now the other approach which has become increasingly popular today is the modified stopper, or also known as the AIP approach. And this gives you a very good access to the quadrilateral plate and the true pelvis. So the the part below the brim of the pelvis is much better visualized through this approach. You can put a plate on both the brim and the quadrilateral plate, the anterior infrapelvic portion into the true pelvis through this approach. If you need to access the upper ilium, then you need a separate approach through the first window of the ilioinguinal approach. And the other approach, which can be sometimes useful and depending on the fracture pattern, is the iliofemoral approach. You can do this with or without osteotomy of the anterior superior iliac spine, depending on the fracture line. Okay, and this gives you access to the front all the way to the joint. Okay, so you can actually access the articular area on the front of the joint, and then you can easily go through the first window. And if you do the osteotomy, extend it almost up to the iliopectineal eminence. Okay, so these are the basic approaches, and you have to use one of these approaches or a combination for your fixation of these fractures. Now, there's certain, especially for these anterior column posterior hemipelvic posterior hemitransverse fractures, this lateral traction with a sham screw into the trochanteric region is a very useful device. You need to do that to make sure that your anterior column can fall back into place and you can fix that. Distraction helps, otherwise you use manual traction. And the sequence of reduction would be first joint distraction, and if you can look into the joint and find any small fragments, you can try to remove it. And this is through the fracture lines. Then you need to you need to reduce the femoral head dislocation. If you have not been able to do this closed, then you need to do this open. You need to reduce the anterior column, and this reduction starts from the periphery to the center. So you start at the level of the SI joint or the sort of top of the acetabulum or the iliac crest, and work your way towards the dome and the acetabular fragment to get your reduction. Because if you don't reduce the iliac blade part, it becomes very difficult to reduce the acetabulum part. And then you would do your provisional fixation of the anterior column, then your definitive fixation, and you have to decide on your hemitransverse fracture. You can sometimes, because these are minimally displaced, you can manage it through your anterior approach. Sometimes you may need a posterior approach to fix a small plate onto the posterior part of the column fracture. Okay, now, as I mentioned, this reduction has to start in the periphery, and this reduction of the iliac blade must be perfect. If this is not perfectly reduced, it becomes more and more difficult to get your acetabular reduction adequately. Okay, so you need to insert these screws posteriorly into the thickest part of the iliac crest. Okay, because so you're going close to the crest, because in this area here there's hardly any the bone is so thin that it's very hard to get purchased. So try to get this screw, and then you can sometimes put a lag screw and a plate along the sort of iliac crest to give you additional fixation. Okay, then you must also remember that your anterior column screws should not get in the way of your posterior column screw if you plan to do it. So remember, it should not block your posterior column reduction. Now, sometimes it may be necessary to increase the displacement, remove any granulation tissue, especially the later it is, the more likely it is that you'll have to remove tissue, etc., between the fracture sites. You need to disimpact the marginal impaction, okay, either directly or through a cortical window. And I'll show you an example of that where there's articular impaction and we've been able to reduce it through the fracture window. And as I mentioned, it's usually the anterior column that you start with. So this is what you use. You can use parabuffs, you can use an iliac shank screw into the supra acetabular area just above the inferior spine, and use this to manipulate the anterior part of the column to reduce it to the crest, and then you can put a lag screw depending on where the fracture line is and the plate across that area. Okay, and then you need to push down on this column at the level of the brim to get this reduced. You can put in your clamps across. You can use this asymmetric reduction clamps, the Matas clamps. You can put a clamp down here, and especially with the collinear clamps, you can actually get the one side of the clamp into this area and try to reduce it into with the anterior part. Okay, so these are the various ways you have to plan your fracture reduction depending on the fracture. And these are some slides from the AO showing how you can do this reduction. You can put screws here, then bring this down, and along with it, it'll bring the rest of it down. And then you can put a posterior column screw as well through the same approach. Sometimes the fracture lines are impacted and incomplete, and we'll show you. So sometimes you may actually need to complete the fracture to get your reduction, because when it's incomplete, it's kind of impacted, and then it's very difficult to get it out unless you complete the fracture. So this happens sometimes. You can put your clamps in different ways to reduce your fracture line, and you need to get your fracture line nicely reduced and then continue with your fixation and plating. Okay, now posterior column screws, you can put in these lag screws coming from the anterior column, and this again will be discussed in the minimally invasive fixation in terms of exactly how you pass these screws. But you start around 2 or 3 centimeters from the joint and just above the brim, and you direct it feeling the ischial spine to this area of the posterior column. And depending on how high the fracture is, your screw length would vary on that, how far you need to go down. Okay, sometimes it may penetrate the quadrilateral surface, so you have to be careful. The other way is to put a spring plate, which again Coxon showed last time, is to put a spring plate across here and down here so that it buttresses the quadrilateral surface. So just go through some examples. This is an interesting, unusual kind of case where the anterior column is involved and the acetabulum is involved and extends all the way to the top. There's no inferior extension in this. This is an unusual pattern of injury. You can see on the CT scan the displacement here, the articular involvement here. And as you see on this other section, you can see how this fragment and this fragment are separated going on to the acetabular area. Now here is where you probably need to use an iliofemoral approach. You use the first window of the ilioinguinal approach, but use the iliofemoral approach to extend down towards the joint. You will need to visualize the reduction in the joint because this is the area you need to get accurately reduced. And then in this case, we use 3 lag screws and then a plate on top. So you can see again, this whole fragment is separated here in the joint. And this has to be reduced accurately because it's right in the dome area that is involved. So we got it reduced nicely. There's a 1, 2, 3, and a 4th lag screw on top, and then a plate to hold everything together. So that it's a nice stable fixation that you can mobilize the patient on. So here's another case, and here you can see the pattern again carefully. Here the anterior column is involved while the posterior is a transverse type of fracture. So classical anterior column, now you can see the column fracture here, you can see the transverse element of the fracture lower down, and again here the anterior column fracture with displacement along the anterior column and the 3D CT. Interestingly, now if you look at the fracture line in this upper part of the ilium, there's hardly any. So it's an unusual combination. Now this can easily be mistaken for a T-type fracture, but if you look at it, the displacement is with the anterior column. So that's another way to distinguish between a T-type and an anterior column posterior hemitransverse. So this is one in which there can be some confusion because the fracture line is almost like a T-type, but if you look carefully, it's the column that the fracture, that the head goes with, that becomes the way you decide. So if you go back on the X-ray, you can see that the fracture is going along with the anterior column here. Okay, so you fix it, there's the plate, and then here we got this lag screw for the posterior column through the iliac fossa, and you can see it's well reduced. You could put a slightly longer screw if you want, but again, this is the post-op follow-up X-rays and a good clinical function at the end of it. This is a more classical type of anterior column posterior hemitransverse, again fixed with a single plate here, one screw here going into the posterior part of the column. Again, a follow-up at about 2 years with a good functional result. So the important part in the ilioinguinal approach, which you should remember, is one is to identify the lateral cutaneous nerve of the thigh. And the second area is this, which is the iliopectineal fascia between the muscle, sort of the iliopsoas muscle, the femoral nerve on the lateral side and the vessels on the medial side. So you don't dissect out the muscle of the vessels. So you leave the vessels with the soft tissue and the fascia along with it, but you dissect out this plane and then you cut close to the bone all the way along the pelvic brim. And once you do this, you have access from the false pelvis into the true pelvis. And that is where a lot of these anterior column fractures are there. This is how you use a spring plate. This is, in this particular case, we used a 1/3 tubular plate to buttress the quadrilateral plate. But as Coxon mentioned, he prefers using a stronger 4.5 millimeter plate to buttress this. So I think this is one more case where you have this anterior column, posterior hemitransverse element to it. You can see the posterior column. This is the anterior column fracture. There's also a iliac pubic rami fracture on the opposite side. You can see the transverse element in the posterior part of the acetabulum here. And in this case, we actually used anterior plate and a posterior plate to fix the posterior column. Okay, and we used a percutaneous lag screw fixation for the opposite side pubic ramus. Where is that? I think I missed out that X-ray. Okay. So now here you can see how the joint is dislocated. This is what would be called a central dislocation of the hip. But again, if you look at it carefully, you can see how this head has actually followed through the anterior column here and is almost sitting anterior to the acetabulum rather than inside the acetabulum. Okay, so this is the posterior side. It's actually gone anterior to the acetabulum. And here again, you have to do your reduction. We could get a lag screw here to fix this part of the fracture line, and then plate extending from the brim down to the pubic rami there. Okay, so this was the case where this is the case where you have a pubic ramus fracture on the opposite side, and we use the lag screw to fix that. Again, this is the follow-up in the various inlet-outlet views to show the position of the screw there. Okay. The one last case where sometimes you can use the medial window of your ilioinguinal approach like a Stoppa's approach. Okay, so here's a fracture where you can see, now here's where you can see this dome impaction at the gull sign very clearly. Okay, this is the displacement along the anterior column, the comminution in the anterior column. And here, since the quadrilateral plate is also involved, we felt that we needed to put a plate on the medial surface of the acetabulum as well in the below the brim. So here you can see the various views, the CT scans again showing you, and it's interesting that this fracture extension superiorly is actually incomplete. Remember I talked to you, so sometimes this becomes very difficult to reduce. In this case, there's not so much displacement. It's important to reduce this accurately before you can get your rest of your acetabular fixation. Again, so this is the iliopectineal fascia. You have the vessels on this side, the muscles on the lateral side. And here you can see we've gone through the medial window like a Stoppa's, extended it more laterally, and you can see the corona mortis here. This is quite a thick, it's interesting when you do the Stoppa's approach, you see this much more clearly. You usually clip them with these Liga clips and divide it. And here we are reducing the dome impaction. You could see that was like a gull earlier. We've been able to reduce it reasonably well. This is pressing on the medial wall. We put our brim plate, and then we use the stopper approach to put a plate along the sort of medial side in the infrapelvic area, below the brim onto the obturator surface as well here. So this plate was buttressing the quadrilateral plate. So I think in summary, it's important to recognize injury patterns in the acetabular fracture. The approaches that we would use for this group of fractures would be the ilioinguinal approach or the anterior infrapelvic or the modified stoppers approach, and sometimes the iliofemoral approach in some situations. The anterior column posterior hemitransverse fracture needs to be differentiated from both column fractures as well as the T-type fractures. You need to do appropriate X-rays and CT scans to really recognize the fracture patterns. You may need to have to deal with the dome impaction, because if you leave it in a unreduced position, it's going to lead to early osteoarthritis. And then you have to plan, once you've got all your fracture patterns sorted out, you need to plan how you will reduce and fix these fractures. So I'll stop sharing there, and if there are any questions, I'll take them. Otherwise, we'll carry on with Professor Kong's lectures.
Thank you so much, sir. One thing which I want to ask, and most of us has confusion, is that quadrilateral plate is part of anterior column, posterior column, or it's just in between? Because like in transverse fracture, anterior column and posterior hemitransfer, it is usually involved, sir. So
it could be involved in either, it could be involved in both column fractures, it could be involved in transverse fractures. So it is in between the two columns, basically, the plate. Okay. So it is the inferior part of the inside part of the acetabulum. Okay. That's a thing. So now it doesn't actually, so it extends onto the anterior column anteriorly and onto the posterior column posteriorly.
One question which Satish Koti is best approach for quadrilateral plate fracture with posterior column fracture.
So I think, so what, I mean, you need to first analyze the fracture carefully. Okay, so is it a posterior column fracture or is it more than that? Okay, so is the anterior column involved or not? If it is only the posterior column involved, then the fracture line will be going through to the posterior column. Okay, so you would approach that posteriorly, but you need to feel inside the sciatic notch to feel the quadrilateral plate for your reduction. And if you're not able to do that, that is where sometimes you may need to do a safe surgical dislocation to actually look into the joint to see your reduction. Okay, so it's important to recognize whether if it's the fracture line from the posterior column which is extending, and very often it will be a transverse element to that fracture rather than just a posterior column fracture then, and a wall fracture.
Yeah, that's correct.
You have something, huh? Yeah.
If there is a posterior column pure fracture,
yeah,
you seldom get a quadrilateral plate.
Exactly, that's what I'm saying. So,
because the fracture goes through the center of the
yeah.
Whereas you will see it more in a transverse kind.
Exactly, that's right.
Inferior posterior wall, a quadrilateral plate with a column. So pure posterior column rarely involve the plate.
That's what, yeah, exactly.
Yeah.
So you could have posterior column fracture line going through part of the plate, but it's never a sort of medial displacement of the plate in that.
That's right. It's usually posterior. The
Yeah.
force is posterior.
Force is posterior to the plate.
So if it is extending from that posterior column only, so when we are reducing the posterior column, it will get reduced.
It
right?
should get reduced, but you need to feel for it through the sciatic notch, because you can't always, if you just look at the posterior part in a transverse element, you could get the posterior part reduced, but the inner part would be separated. Okay, so unless you feel it properly, you will not get a good reduction, and that's why you need to make sure that you have put your finger through the sciatic notch and felt the inside of the fracture. It's usually part of a transverse fracture again. If it's just posterior column, when you reduce the posterior column, but you still need to feel the inside of it to see that it's reduced.
Yeah, that's for the T part, the vertical
Yeah.
end of the T.
Yeah, especially for the T cord. Yeah.
And so when we say transverse part, that is elementary fracture, means that is pure fracture. So it's always that plate, quadrilateral plate is not having combination in that, or it may have.
So you can have transverse with posterior wall. Okay. You have a pure transverse fracture. You can still have some comminution. Okay. It doesn't mean that you can't have comminution, but it's unlikely that you're going to get a more than that, because otherwise there'll be some other fracture line either going down or into the posterior area or something, a wall fracture or something, for it to be more comminuted.
So we have few more questions, but I think we'll request Coxon sir to first present his lecture. After that,
Yeah.
I think the question pertains to the AC-PHD, so maybe we can answer it now.
Okay, sir.
In case of AC-PHD, do we need always to fix both columns? That's the question.
Okay, so you would want, so if the posterior column is totally undisplaced, then you would still try to pass a screw into the posterior column. Okay, so you need to try and pass a screw. Sometimes it's been, I remember one case where we really couldn't angulate. This is a very obese patient, and it was being very difficult to get that angle for the posterior column screw right. And so in that particular case, because the posterior column was not displaced, we actually left it because the anterior column was quite securely fixed, and we had been able to get a screw through the into the quadrilateral plate from the plate into the posterior part of the quadrilateral plate, because that was off. We were able to get a screw into that. But otherwise, yes, you would at least try to put a posterior column screw in from the anterior part. You don't need a separate incision for it. Okay, but rarely, when it's not getting reduced from the front, you have to go to the back and reduce it. But it's I had to do it in that one case. So ideally, yes, is the answer to that. Sure.
All right, I'll share my screen if there are no further questions.
Yeah, please.
Okay, so now we come to the last of the internal fixation parts of the fractures of the acetabulum. Next week, we will be doing some minimally invasive and the maximally total hip changes. So the bicolumnar fracture or the both column fracture is the result of energy impact through the hip and the pelvic ring. So it's the lateral rollover kind of fall from height and landing on the side. It's fairly common. It's probably around 20% of acetabular fractures. And you have to understand this pattern to recognize what you need to do in treatment. I will show you how to recognize the spur sign, which is pattern harmonic of this kind of fractures. But certainly in these cases where it's very difficult to see, and sometimes with a lot of bowel shadow or obese patient, the study of the CT scan will help you in your surgical planning. And sometimes you can actually advocate conservative treatment with bicolumnar fractures, which appear to be the most complex, but sometimes because they are fractures, the unstable part may be above the joint, and the joint may be rather congruous. Then you can do a conservative treatment, and I'll show you some the reason why. How do you recognize the bicolumnar fracture? Again, it's just the same simple CT scan will tell you. The first thing to do is to recognize what they mean by bicolumnar fracture. So fractures from the iliosacral sacroiliac buttress will never reach the acetabulum. So they will break off above the acetabulum, but the anterior column and posterior column may or may not be separated. Usually they're separated. Very rare to get a wing fracture like this. So here we go through the lines again. You see the ilioischial line. You see the iliopectineal line. You see the wall, anterior wall. And then you'll see something above the joint. So you can see here an anterior column fracture and this is a transverse component. But anything that reaches up to the iliac wing, up to the crista ili here, must denote a much more higher force, and therefore they will be considered to be a bicolumnar fracture. And then that is the picture. So where does the spur sign come in? Well, you get sometimes an obturator oblique view. You can only see the spur sign from here. Sometimes they are horizontal and straight. Sometimes they are spiked. And the reason why you can only see that there is because this spike is actually the remnant part of the posterior iliac crest, which is attached to the SI joint. And the anterior iliac wing has been medialized and therefore exposing the lateral border of the iliac table. And here sometimes they look like a spike, so it just depends on the pattern. It's either a rectangular part or a spike. So that tells you that this is classically bicolumnar fractures. No other fracture produce this pattern. So it has to be an extra articular spike above the hip joint. So anything at the hip joint, it could be the wall fracture of a posterior column or posterior wall fracture, because the hip has medially translated, leaving the remnant of the iliac crest behind. There, and you notice that often the joint is congruous. That means the fracture did not go through the joint, it went above the joint. And you must always see this break in the iliac crest, as I showed you in the last X-ray. Some of them can be not displaced or not picked up on plain X-ray. CT features, again, bicolumnar, anterior, posterior column, so it's a transverse pattern. Sometimes you get comminution of the posterior wall and a quadrilateral plate, and sometimes these articular surface can be flipped over, and often because they are reduced by manual traction, and these falling in the wrong direction. Certainly, this means you need to go into the joint. The displacement is through the weight-bearing area to the iliac crest, and you can see here the CT picture of a spur sign. And again, 3D CTs give you the study iliac crest, goes to the corner of the SI joint, and then after that, this will be a bicolumnar fracture if this posterior buttress does not enter the joint. It can be confused with the anterior column hemi-transverse, as we have seen before. And when you do your rotations of CT scan, you notice that this actually is part of the ischiocytic notch, the greater sciatic notch, but it incorporates the acetabulum. So this is not a bicolumnar. Bicolumnar will break out from here. This has gone into the joint, so it's an anterior column and a posterior hemi-transverse. So they are very similar, and they are often treated in a similar way. AO-OTA classification. So this is a type C, complete articular both column fracture. You have the high iliac, which is the C1. The fracture goes through the iliac crest. And the subtype of, if they are just in three parts like this, is a 0.1. C1.2 will have one that has an anterior column fracture. C1.3 will have an anterior and a posterior column fracture. So this is a multi-fragmentary involved in the joint. C2 are called the low iliac fractures, so they exit at or below the anterior superior iliac spine, and they stay low and they still exit through the back. And again, this sacroiliac buttress does not articulate with the congruent hip joint. Again, 1.1, 0.2, 0.3 is when you have an anterior, you have a posterior, or in a lower one. It is three parts without the involvement of additional joint fractures, then it's a C2.1. C3 is when the fracture will go into the SI joint. So there's instability of the SI joint, similar to a crescent fracture. And again, this is slightly different. C1, you will have 0.1, you will have a high iliac. 0.2, you will have a high iliac with a joint fracture, usually a posterior, and then the C3 will have a low iliac with a posterior column fracture. So this is the classification which can refer to as best as I can to make it into a diagrammatic form. What is the role for conservative treatment? As I mentioned, these most complex of fractures can be treated conservatively, while some of the transverse fractures, that is single fracture plane through the joint, need to be operated on. I'll give you a case that we did many years ago. It was a 20-year-old lady who was hit by a car, and CT, transverse fracture, that's above the joint. So this is a clearly bicolumnar fracture. And this is a C2, C62, C1.1, so it's a high islet with 3 parts only. And we decided, she refused surgery actually. We offered her surgery. It would have been difficult, but she refused. And she was put on traction for 5 or 6 weeks. Then she went on partial bearing for 6 weeks. And she actually disappeared from follow-up until she came in for a compensation report, a 3-year follow-up. So we took some x-ray. She don't want the CT scan because it's too much radiation. But you can see that there's very good congruent joint. And she's a commercial photographer and can carry a heavy tripod up and down in her work. So there is a role for conservative treatment, especially in the elderly, for example, who sustain these fractures, and they can place on traction and avoid the risk of major operative risk. So when you do want to operate, you must recognize this pattern. So if you get this book by Marvin Tao, you will see in one page all the patterns you can see. Iliac crest fracture extending to the ischial sacral buttress, separated from the hip joint, and then the anterior column type. And you must perfectly reduce the iliac crest. Just as Dr. John said, in the anterior column fracture somewhere here, this is the first point of contact. And the reason why, because you have a split in the iliac crest, you will see it like a cross like this. If you don't line this up, there's not going to be many matching at the other end of your, like, which is of course superior to the joint. So you start off with the leg screws. I like to use leg screws with a pointed reduction forcet, and they must be very accurate. And don't forget that they can be rotated. They have to be put in line until the surface is flush and the height is flush. Then you reduce the iliosacral buttress for the spur sign, and this is what you do when you pull them in. This is a spur sign, so you have to manipulate your reduction here, and then push in this, because this medial anterior part has been medialized, and therefore you have to bring this out because the spur is posterior and the anterior column is medial. So you have to reduce this. So that is a reduction of that spur corner. Then you have this fragment. This fragment is often seen in bicolumnar fractures if you go into the ilo-internal approach, and it's said to be the keystone fragment, which is like a jigsaw puzzle. Once you fix this in with a small leg screw, you have reduced the break between the iliosacral buttress and the anterior column. So this is another key point. And finally, having done all this, you will see that you're actually handling yourself a T-type or a transverse type fracture, which you can then go in and fix it as if it was a different kind of fracture that we talked about last week. Okay, what are the surgical approaches? As in most complex surgery of the pelvis and the acetabulum, you need to know quite a number of approaches, and these are the standard ones. But how do you select which one you go to? I always look at the maximum displacement. If it's medially, you have to go from inside out. If it's laterally, then you go from outside in. If it's posterior, you come from posterior. So it's very simple. Then you got to see, can you see your fracture reduction? Can you see the joint? Reducibility, you may be able to see it, but you can't effect reduction. So that could be a pull and push technique, or maneuvering the hip joint, or traction. So you need to get that reducibility study. Then you got to put your instrumentation. So there are some places like this, it's so comminuted. A medial brim plate on the stopper approach may have problems trying to secure good fixation because it's below the brim. So your plates are always just on the brim, but this is deep to the brim, and that could be difficult to fix with something that runs from front to back. Then look at the skin. You may have Morel Lavallée and a bad skin, or patient has been delayed with some bed sore. You may have to learn all these approaches to avoid all this. So one of the common ones for bicolumnar is Letonel showed in 1960s was the extended iliofemoral, and this gives you a good exposure of the outer border or the lateral wall of the iliac wing. By doing osteotomy, trochanteric osteotomy, you can move all the muscle attachments further back, and you can actually reach the ischial buttress. from which you can actually put up a plate. Okay. Then the next one would be the iliofemoral, the workhorse approach. Again, one of my favorite. I think John likes this too. We were all trained traditionally. And of course, the stopper approach, exposure, and the modified stopper where you have to reach this part through a separate incision because stoppers can reach just about the iliopectineal elements. Okay, this acetabular spring plate was designed not by me, it was designed by people like Jeff Mas and Marvin Tao. And what they did was when you do a lateral compression, you will see the opening up of the medial side. There is angular changes which you need to reduce at the joint. So you have to bring this up, and then the power of the screw will put your plate by reducing it flush. So contouring this plate is number one, very important. But the power of a single 4.5 bicortical screw will reduce this. And you cannot over reduce because of the fractures and of course because of the deep ligaments of the ischial-spinous, sacrotuberous sacrospinous ligaments will never allow you to laterally displace this acetabular. Then you put a neutralization plate. So in order to do this, you must go from inside out. So ilioinguinal or intrapelvic approach to do this plate. It takes care of the problems of having a very low quadrilateral plate blowout. The steps of reduction, as mentioned before, very important. Always do the eyelet crest, get it right, both in rotation as well as in height. Then you do your drill bit, always leg screw, over drill, near hole, and then usually I use 4.5, 3.2, and you can do it with one screw or you can do it with two screws. Then you neutralize it with this is called the magic screw, which we'll talk about next week. And it's the anterior inferior spine screw that goes right down to the back, very long screw. And then by doing this, you have converted the bicolumnar fracture to a transverse or a T-type fracture. Sometimes I use this clutch. They're very useful, but you need to get a good wire passer. And this, if you see a spike at the back there, which you can catch with this wire, this is a very simple approach and it compresses the fragments together, especially when you have wall fractures. And then you do the posterior column screw. So this is what John was trying to show. Finger in the deep pelvis, the true pelvis. You can actually place two screws and not hit the joint. And this is parallel and about a centimeter from the edge. You can put another 1 centimeter more along the brim. And you have to drill and feel with your hand in order to miss it. So it's just parallel to the quadrilateral plate. Then you can use an intra-acetabular screw, which I showed the last time for key fractures. And finally, you put a neutralization plate. So this buttress plating, again, as I said, is Marvin Tao, Jeff Mas have showed this plate. So they used to use a small, it's a 4.5 that is very thin, which you have seen John show in one case just now. I prefer the 4.5 because you can really spring this and the patient can walk quite easily. These are very thin plates. And sometimes if you don't add your additional screws, you can have secondary displacement medially for the hip joint. Then it's just a single screw behind along this line, behind the iliopectineal eminence, you will never get into the hip joint. And it's sprung like this. So outward view, you can see the spring. This is not going to the joint, it's going behind the joint. And then your posterior column screw as well. So it's very secure and you can actually walk the patient for this style minimally displaced. And then you can place your neutralization plate in this. Here's a case that I want to show. A young man, a truck driver, was in a collision, front-end collision, was in shock. Pelvic compression, of course, was painful and the hip was unstable. Internal rotation deformity of the hip. So this is very common for bicolumnar fractures. Always examine for neurological deficit. He didn't have any, and the catheter was clear. So this was the X-ray, and again you can draw your lines, the ischial line, iliopectineal line, wall fracture, lateral wall fracture, part of the anterior column, posterior wall fracture, break in the obturator. So it's a complex. But try to go up here and try to see if you can see the eyelet crest fracture, because you may think that this is a transverse pattern or anterior column and posterior and transverse. but always look up there and you'll see things that you'll see. Here's a very good idea, a picture of an islet crest fracture, where you have a double shadow. Transverse pattern on the CT scan, again, supraacetabular fracture, the spike sign. And 3D CTs are very good to study pattern. And they always have this V pattern of bicolumnar fracture. So in the planning, we can do the X-rays, but I prefer to use the CT because you can rotate it to the one you want. So I just show you the approaches. Extended iliofemoral is standard approach, but it can be modified from the ilioinguinal by taking a side cut down along the Smith-Peterson kind of approach, and you can get a modified iliofemoral, ilioinguinal to become partly iliofemoral. But if you want to go to the back here, you have to do a full iliofemoral. Modified stopper coming in from medially. You can do the ilioinguinal where you can reach both the crest, the brim, and into the deep pelvis, which is my favorite. Then you have the iliofemoral and the phalansteal where you do a iliofemoral down here in order to reach the to pass a wire, and then you have a suprapubic like a mini stopper approach. So accurate iliac crest reduction, so that's the screw there after reduction, forceps reduction. Transcolumnar wire, so you have a spike like this, it's very nice to do this wire. You just have to get the right wire passes. You can use a cable, I prefer a cable, but some people just use a coil wire, double up the strength. Then you do the phalansteal approach and use your pointed reduction forceps or ball spike washer and just push the quadrilateral plate. Then you hold the reduction with the acetabular spring plate, and then finally the neutralization plate supports it. Post-op CT, I always do post-op CT. You can see the ring, the eyelet crest has leg screws. We put an additional leg screw for the fragment just short of the joint. Then we did the circlage wire, and then we put the spring plate and the neutralization plate. And the post-op reduction was good. I'm sorry, I don't have a picture of the joint, but here you have to restore the columns and the joint wasn't so important. But you can see that it's congruent in all the three I views and the OO views and the IO views and the AP views. So the CT audit is very important. Look at the coronal pictures, the axial pictures for the fracture, and then the orientation of the head and the quadrilateral plate. So you can see the quadrilateral plate has restored back to the original. And 6 weeks function, we can early mobilization. This is what he was 6 weeks, and in 3 months he was back to his driving of the truck. There's an alternative fixation. This is a lady who is on osteoporotic treatment. She both has acetabular fracture type C3, okay, which means it goes into the SI joint, and then the E2.16, which is internal rotation lateral compression type fracture. So again, you can see the fracture supraacetabular goes to the joint, and she was osteoporotic. Okay, you can see that she also osteoporotic. And then we use plates. So instead of just using leg screws, which may not hold, we have eyelet crest plates, we have a spring plate, we have a brim plate, and 4.5, you don't have to put in too many screws, and the patient is well reduced, the hip joint is congruent, and she went back to work after 3 months. So the take-home message is that these fractures require a very clear understanding of this pattern, and then you can choose to decide if you want to treat conservatively or operatively, depending on the displacement, the stability, etc., and of course the patient's fitness for surgery. If you don't understand, you start fixing the acetabulum instead of going to the eyelet crest, you will probably end up with poor results because you must go in the proper steps. So beginning at the crista ili between the anterior column and the iliosacral buttress. So that converts it into a transverse type fracture or a T-type. Look for that ketone fragment, which sometimes you can see on the stopper approach, but you certainly can see it in the ilioinguinal approach. Then you must fix it in place to fit the jigsaw puzzle. This is a key, that's why I call it a keystone fragment. Then you do your spring plate and the intrapelvic plate, reducing the anterior and the posterior columns through your preferred approach. And finally, some of these cases, as I mentioned, can be treated non-operatively. You put on traction and then do your X-rays to see how they work. Thank you very much for your attention.
Thank you, sir. Thank you so much, sir. So, we have a few doubts about when we are fixing the posterior column, sir. We are using the lag screw. What is the ideal size of lag screw, sir? Do we prefer the mini lag screw or the 3.5?
The leg screw for posterior column, the posterior column screw, I only use the 4.5. So it's a cortical plate. Cortical plate. Yeah, a cortical screw. Pelvis, okay, I seldom use a cancellous screw. Although it's a cancellous bone, but in a young patient, the cancellous bone is as strong as the cortical bone, and you keep it between the tables, because this is a curved table, right? It's not a straight table. So if you put a screw in, you're going to catch the thick cable and squeeze between the cables, and you don't need cancellous screw, cortical screws, and you can actually see cortical screw bend in the pelvic rim. So I use a leg screw, so 4.5 leg hole, and then 3.2, and then I depth gauge, and then after that pass the cortical. Everything is by power, so it's much faster.
In Indian scenarios, that is for John, sir.
Sorry.
4.5 is okay.
Well, I don't. I mean, we sometimes we tend to use 3.5 screws. We always have this discussion because I find it. I mean, I'm sure we can use 4.5 screws. I used to use them for my pubic symphysis plating at one time. It's possible, but every now and then you'll find bone which it's very difficult to use a 4.5 screw. But certainly, it will give you more strength and hold than a 3.5 screw. There's no doubt about that. But we tend to use 3.5 more often.
Yeah, I think it's quite important if you're going to do percutaneous screw techniques.
Yeah.
Because in 3.5 plate, you have to put many screws to hold the plate.
Yeah, true.
But if you start to do percutaneous, like me, you'll be doing a lot of 4.5s because firstly.
No, in fact, for our percutaneous, we even use 6.5.
Okay.
For the if we can get it in. Yeah, so it depends. So for certainly for the sacroiliac screws, it's 6.5. For some of our anterior column, we've been able to get a 6.5, and also for the posterior column screw, but and 4.5 as well. So we would use, but so 3.5 for some of our anterior column screws, we use 3.5 because using 6.5 becomes very difficult. But we haven't actually tried 4.5. I think we don't get, so we've got the 3.5 screws in the long lengths. We don't actually have the 4.5 screws in the long lengths available with us for some reason. Okay. So we either have to use 3.5 or 6.5. Although I've asked them to get it, but they get it, we have it for some days. Then once we use it, they run out, and because they don't have it in supply in India. So they have to get it from outside, and it becomes a bit difficult to get hold of them.
Okay.
And the Indian companies, I don't realize on the long screws.
No, they can't sell them.
Yeah.
And so when we are putting the lag screw over the posterior wall, almost always we have to follow it with the plating over that one, sir. So usually when we are putting the screws, it is over the rim, and when we are putting the plate, it is usually lateral to that. Why it is so, sir?
You can put the plate on top of the posterior column. It depends on how you contour the plate. Some of them may be.
You're talking about posterior wall and posterior column. Yes, wall screws have to go in a particular direction, okay? Because if you don't go from front to back, you'll end up going into the joint. Okay, so you have to make sure your screw direction is right, and it goes into the posterior column from the wall and not into the joint. and then your plate is to buttress, and it buttresses ideally between the fracture line and the rim. Okay, it should not be on the lateral to the fracture line. Okay, then it's not going to buttress.
And so,
Posterior to the fracture line, then it's not going to buttress the fracture.
so when you're putting the MATA plate from the posterior side, where the actually the proximal two screw and distal two screw where it should go, and when you are putting from anterior side over the anterior column, where it should be directed.
So for the posterior column, you have your posterior wall fracture, and you want to get two screws superior, two screws inferior, and buttress it. Sometimes some people manage with one, but I prefer two screws, and usually two lag screws. So that would be the standard pattern. It will be a 6, sometimes 7-hole plate, depending on the size of the posterior wall fragment. And your plate usually goes down to where you have the groove in the ischial tuberosity. So you have one screw into the groove and one into the ischial tuberosity, and the two proximal screws superior to the fracture line. And depending on the how much area the fracture covers, you may have to use a longer plate. If you use too longer plate, then in anteriorly you have to bend it enough, otherwise it will sit off the bone anteriorly. Because if you can imagine the anatomy, it's like that. So your plate has to come like that and then go down if you want it to sit on the bone. And then more anterior go, the more difficult it becomes to retract the muscles. So that's where if you do a trochanteric flip, it might help you to get the plate more further anteriorly.
And when you are putting MATA plate on the anterior column, then where it should go, sir? The screw.
Okay. So again, you have ideally 2 or 3 screws into the pubic rami, superior pubic ramus, and then proximal to the fracture line. And then it should buttress the column fracture.
And so sometimes you use MATA plate over the quadrilateral plate, means inside, from the inside. So in that case.
So if you're using a spring plate for the quadrilateral surface, then you will use that first and then the plate on top of that. If you're using a inner plate from the EIP approach, that's different. So that you can put it in any order. It's not really necessary. Usually there I would fix the rim first and then do this. Rim first and then do this.
Yeah, for your question, I just pull out one slide. So if you look at this, you see.
Okay, slides, yeah, great.
So you can see that we just go for the pubic symphysis. Okay, so nothing here, and then the buttress, the iliopectineal eminence, and then two screws at the back. That's all.
Yeah.
So sometimes these are just need to buttress in, including a wall fracture. You may have to add an additional screw, but that would be very dangerous if you're not too a bit long. You actually end up in the joint. So we use the plate as a buttress. So you can actually not over contour this plate, but you use a ball spike punch, put it into the hole there, use a mallet and knock it down. So directly onto the plate, and that molds the plate against the bone, especially where there's a hollow. That is the superior part of the superior pelvic ramus.
Yeah, so it's interesting. The MATA plate, actual MATA plate, allows you to use 3.5 as well as 4.5 millimeter screws. That's interesting. So we have done that. We've used combination of screws, but we don't get the actual MATA plate anymore. So this one doesn't allow you to use 4.5 millimeter screws in them.
Right.
So you have to use 3.5 in them.
So, yes. Sir, in case of both column fracture, when usually at least we should have 2 fragment in the inferior and 1 superior fragment. So for the rotation, how to control the rotation, because there are 3 fragments, sir. When it is rotated, if a few of the fragment is rotated, how you control the rotation before reductions?
Usually asymmetric clamp. The best is actually the asymmetric clamp. One outside the outer wall of the ilium, one on the inner wall of the ilium, then you grab it. If you have a smaller fragment, you can use a parabus. you can pass it through a small cut on the gluteus and then just bring it down. So it all depends on you catching the ilium and then you're trying to rotate to match it. You got it?
Yeah.
Yeah.
Yeah, absolutely. So you have to, and you start on the periphery. So you start with matching the crest exactly right. Okay. So, and if you, unless you get the rotation right, the crest is not going to manage. So you do that visually. Okay. So make sure you can see the fracture line and it's reduced adequately. Don't rely on just the inner side of it, because that's when you can get rotation. So if you get both the inner and the outer, so you can just dissect out the muscle a little bit and feel the outside as well. Hold this with either what you mentioned is the clamp, or you can use a Farabuff to hold it, or even a shank screw to kind of manipulate that anterior part and make sure it's exactly lined up. Put in provisional wires and then put in your screw, lag screw. And then if you need to put a plate, you can put a plate along the margin of the crest.
And so you have mentioned in your lecture about the very small fragment, if from the ileum it is coming out, even for that one is also very important. In both the lecture I have seen. So for that one, sir, we have to fix that one with the lag screw.
Yeah, again, this is what you're talking about, this triangle.
Yeah, the triangular fragment.
Yeah,
no,
you have to have.
Talking about the other lower one.
This one.
Lower one.
Near
one
the
a small
brim,
fragment you have shown, sir.
the triangular fragment near the brim.
The keystone.
Puzzle.
Yeah, the keystone fragment. Yeah.
Yeah, keystone. You can see it. Let me go back. Let me go back on the picture. You have to get it from the book, so you can actually see the book very nicely. What you need to do. Yeah. So again, this is the buttress. This keystone fragment.
Yeah.
Yes. It reduces the ischio sacroiliac buttress with the anterior column. If you don't match this, the joint is incongruous. So this is a very good spike. Before reduction, for doing this, you can use a ball spike and push it down until you get this, and then you will see a small fragment. It looks very unimportant, but it's really a keystone. Put a 3.5 leg screw and hold it in place. And before you put your spring plate, because if you put your spring plate without this fragment in place, you may actually cause a displacement between the iliac buttress and the anterior column at the joint level.
Yeah, they have this in the although that is not the same as doing it in real life. In the AO bicolumnar fracture model, they have this triangular fragment there.
Yes.
So, and so one thing which is like when you are managing the Pipkin type 4 fracture, that is means when it is femoral head fracture which is associated with acetabular fracture, what is your approach? How you go?
John, before you try hip replacement.
Okay, so it's yeah. So what you would do is, if the acetabular and femoral head, okay. Now, usually you would do a closed reduction first, okay. If it comes easily, don't struggle too hard in that, because I've seen people who manage to fracture their neck in trying to reduce the head. Mm-hmm. So gentle closed reduction. If it gets reduced, then the best approach would be to go posteriorly for your acetabular fracture, okay? And for the head, it's usually easier to fix it from the anterior side. So there you would do a safe surgical dislocation and do it your femoral head fracture from the anterior side. If you have the head has been reduced, then we tend to use the iliofemoral type of a Smith-Peterson approach, Luther's approach. Okay, so a modification of the iliofemoral or the Smith-Peterson, just the vertical limb of the approach, and then we can fix it from the front. But it's important to study the fracture line on the CT, because sometimes these fracture lines can vary. Okay, So sometimes if you're coming from the anterior side, the fracture is slightly oblique and it's very difficult to get your screw. So there, safe surgical dislocation is not a problem. But with the anterior approach, sometimes the line of the fracture line may make it difficult for you to put your screw in exactly the line you want to put it, in terms of it has to be ideally perpendicular to the fracture line. Okay, so check your CT and then decide what approach you're going to use. So people now, we still use the posterior approach sometimes, where the hip is irreducible and we are going from the back. Then we sometimes use the posterior approach if we can visualize it from the back. Okay, so it's only if you can really visualize the fracture from the back, we get in a clamp and put in a couple of screws. We've done it in trying to avoid going anterior, but by and large, we would go anteriorly and then do it. So there are a couple of cases where we've actually done it through the back itself. And that's what we used to do earlier, before the sort of safe surgical dislocation approach was popularized. So we would do it from the back. And we've got some good patients with very good long-term results with that. But by and large, by what the literature says, that the avian rates are actually less if you do it from the front than the back.
One thing, sir, which I have the concept, whatever I have developed, is that when it is a transverse fracture, it is usually commonly, it can be approached from the posterior side, because the head is going usually posteriorly. If it is a transverse fracture with posterior wall, or when it is anterior with posterior hemitransverse, the head is usually out. So it is managed by anterior approach usually, sir?
So again, we discussed this so many times. Your anterior column, posterior hemitransverse fracture, the head follows the anterior column.
Yes, sir.
As opposed to the T-type fracture, where it tends to follow the posterior column. Okay, yes. Now if you have a posterior wall fragment, then you have to go posteriorly. It's almost impossible to fix the posterior wall fracture from the front. Okay, unless it's like a lateral fracture, which you can approach through a Smith-Peterson approach.
For the anterior column posterior hemitransverse, by going to the front, you convert this difficult one into a simple posterior column.
Yeah.
You have to anteriorly column close it. You just have a posterior column to handle. So you can do it from the front if you're very good with leg screws and you can effect reduction. Spring plate also can, or you can just use a ball spike pusher and put 2 leg screws. You can put a infra-acetabular screw, and that will secure your posterior column. But if it still, for some reason, has a wall fracture, or is unable to reduce because maybe
you have to go to the back,
blade incarceration or fragments or something, and then you need to remove, then you've got to convert to a second approach from posterior.
Yeah, because sometimes it is sort of jammed in on the, and whatever you do in the front, this doesn't reduce adequately. Or there's a wall fragment, then you have no choice. Then you have to put, if it's a displaced wall fragment, unless you think it's a wall fragment which can be ignored for some reason, that's different. But otherwise, you need to go to the back.
And so for this fracture, or even for the both column fracture, how often you have to use 2 approaches? And when you are using the 2 approaches, is it on the same day or on different day you are doing the surgery?
Okay, so I think it, sorry, yeah, Coxon?
Sorry, I mean, I was just answering for the both column fracture. You usually, it's not common to do 2 approach for columnar. Unless you have an additional wall fracture or a segmental fracture of the posterior wall. Most of the work is done from the front. So it's not common to do 2 approaches. But if you need to do 2 approaches on any acetabular, try to do it at one sitting. Because by the time you come in again, it may be a couple of days. Then the screws get loosened or something like that, you're going to go. So do it on one day.
Yeah, and also depends on the magnitude of surgery. If you find that you've gone through the front and it's bled a lot, the anesthetist is a bit worried, then you might wait. But otherwise, ideally do it on the same day if possible. Now, your approach, again, as he mentioned, you go for the side that's displaced more first. The T-type fractures are the ones that often need two approaches more than the both column fractures. Okay, because sometimes the two columns are separated completely and you can't reduce them accurately without getting at both. So those are the ones more often where you might need both approaches, especially if they've come a bit late.
And so if it is late fracture, like when the reduction is not achievable after a few days, then how you go for that?
Late means how late?
Means like when there is a fibrous union about 20 days after that, 3 weeks or...
See, 3 weeks you would still try to do it. It obviously needs more extensive dissection, more blood loss, everything else. The problem is when they come much later and it's an intra-articular displacement, then it becomes very difficult. And so if you have a posterior wall fracture which is actually dislocated and it remains like that, which we get sometimes, you can do it, but the results are not so great. The AVN rates and all are very high. Even the posterior wall fragment, because you end up dissecting everything off it, even the wall fragment can go into AVN.
Yeah, the other thing is the pelvic floor. Anything that medializes the hip joint, like a transverse fracture, posterior column fracture, or T-type fracture, the pelvic floor contracts. So when you try to reduce it, you need to push it from medial to lateral to effect reduction of the polyhedral plate. That can be quite difficult if you do not strip off the obturator, the sacrospinous ligament.
Ligaments, in fact, yeah, you need
ligaments contract. So usually after 3 weeks, it can be pretty difficult.
Yeah, and they bleed a lot as well once. So
That's
after the
heterotopic ossification.
yeah.
So in your talk, Coxon sir, you have mentioned about the secondary congruency. So how often now you use that conservative approach for that cancer? And if you are using, what advice or what mode of treatment you are giving?
For the secondary congruence of bicolumnar fractures?
Oh, yes, both column.
Because we are seeing some not markedly displaced bicolumnar fractures. But by just applying some traction while we are working the patient up, you find that they have some secondary congruence. So you look at the study, the acetabulum. You can do the CTs and all that, maybe after about 10 days. And then you look at the acetabulum, they seem to be well reduced. All you need to do is wait for extra-articular healing, bony union. And then the cup is still preserved. You can later on go in and do a total hip on an elective basis. But if the head is rubbing against the bone and it's not reducing for any reason, then you can do the open reduction. But of course, with osteoporotic bones, they can be quite difficult, and secondary loss of fixation plus all the other operative risks are quite high. So in the elderly patient, I would try a traction approach first. And then sometimes the traction slightly abducted, the leg is probably abducted in about 30 or 40 degrees. And then after that, do some passive traction exercises with a femoral pin or CPN or something like that. So you are hoping to mold the cup. You can forget about everything else. If they are held in together, they do unite. The pelvis tends to unite quite fast, and at least enough for wheelchair weight bearing at about 6
weeks. So this is more likely in a both columnar fracture because the acetabular fractures are separate from the axial skeleton. Okay, so they are actually, if you put them on traction, they will mold around the head with a bit of medialization. Now, that doesn't mean you plan to treat them non-surgically, but in elderly patients or where the bone is very osteoporotic or multiple medical comorbidities where the risk of surgery is high, it's an option where you can maybe get a good result in spite of conservative treatment. Okay, so some of them do. We've got 1 or 2 cases which have done very well, but it means keeping them on traction for at least minimum would be 4 weeks. Sometimes maybe longer for the bone to heal before you can leave them off. So that's the other thing that you need to look at.
In next week, you can try minimally invasive.
Basically, exactly. That's the other option nowadays.
So you
Especially
can do a-
elderly patients. A lot of people are doing this in the,
But you must get good reduction first.
yeah. Yeah, otherwise, if you try minimally invasive without reduction, then your screws are going to be all over the place.
Insertion of foreign body.
Yeah.
Even sir, when I have seen 1 or 2 cases of conservatively treated acetabular fracture, that is, many of them used to develop the bed sore and all. So what we can do for them, because they are just putting skeletal traction and they are not changing the position and all. Is it like so, sir, or do we start them on exercise something?
See, that is your patient care. Huh? You have to make sure, okay? Now, this happens because you're neglecting the pressure areas, okay? I mean, in Stoke-on-Trent, they treat all their spine fractures, a lot of their spine fractures conservatively. But because they have such a high level of nursing care, etc., they don't get bed sores, okay? Even though they are paralyzed. Okay. Now, if you look after them properly, they will not get bed sores unless they've come late. Then it's a different issue altogether. Okay. So if they come to you and you put them on skeletal traction under your care, then it's your responsibility to make sure that they don't get pressure sores. Okay.
So I think
Blame it on the patient. Huh?
thank you so much, sir. It was very nice talk, and probably we'll have on the minimally invasive and the THR part of it. Yeah, next week.
Yeah. We're getting to the end of the.
Last one.
Yeah. Great. Okay. All the best, everybody. See you next week.
See
Thank you so much.
Bye.
Bye-bye.